Okay, well, I think it's very important, these risk factors which I have talked about. Um, I mentioned the study done in year 2000 by Donors Group, and that was using FISH to define subgroups of patients. And as I mentioned, the patients who had deletion 17p had the least favorable outcome with a poorer survival. And the intermediate category were patients who had deletions in chromosome 11. And we recently completed a study with the CLL Research Consortium, and what we found actually was very interesting is that the same hierarchy applied, namely patients with deletions in chromosome 17 still were faring as the poorest subgroup, but their survival has improved. And this, we think, is through the advent of chemoimmunotherapy or immunotherapy regimens, and also getting the word out that you should not treat these patients so that they're almost near exhaustion with chemotherapy. It's not going to work. And so the survival has improved with the patients with deletion 17p, but it's still worse than the rest of the patients. The patients who had deletions in 11, the long arm of chromosome 11, still were not showing much improvement over what was published about 17 years ago. They still did not fare as well as patients who did not have any detectable abnormalities, or patients who had deletions in chromosome 13 or chromosome 6 or trisomy 12. And so when we looked at the data for patients treated with the early trials with ibrutinib, it was interesting because it was noted that patients who had had prior treatments, many sometimes up to 5 or 6 prior treatments, were treated with ibrutinib in the earlier treatment trials. And you could see that patients were over time developing resistance to the treatment with ibrutinib. And so you can define the progression-free survival when patients, even though they were taking the drug, would now show that they had to stop the drug because they were developing resistance. And in that analysis from the early trials, it was the same hierarchy going on again. So I was saying, perhaps here we go again, that there's something about this hierarchy. But I've always maintained to patients that really we shouldn't put the onus on the patient. I like to not say to the patient, that you have bad disease, but rather we just have bad medicine for your disease. If we have better medicines or better treatment strategies, we should be able to turn a bad prognostic marker into one that's not so bad, or maybe even favorable. I think what we've been able to show is that we were conducting studies with ibrutinib. I helped chair the study that compared patients over age 65 who were treated. They were randomized to receive treatment with either chemotherapy like chlorambucil versus treatment with ibrutinib. This is the RESONATE-2 trial, and this was frontline therapy for patients over age 65. And in that study, we found that patients who took ibrutinib and continued to take ibrutinib enjoyed a longer progression-free survival and overall survival than patients who were taking chlorambucil. And so this trial led to ibrutinib being registered for treatment in the front line, namely as initial therapy. But we began to look at the data, and it appeared that the patients who had deletions in chromosome 11 actually were doing quite well. And this seemed to go against what the former studies had indicated. So with help of the members who conducted all these trials and also with Pharmacyclics, we were able to go through the data of patients not only treated on the RESONATE-2 study, but patients treated on the RESONATE-1 study, which is patients who've had some prior treatment who were randomized to receive either ibrutinib versus ofatumumab, and also data from the HELIOS trial. Namely, these patients were randomized to receive ibrutinib versus a placebo, and that was done in the setting of bendamustine and rituximab. So what we were able to do by combining these 3 studies was to gather a large group of patients together who have known cytogenetic features. We excluded those patients that had deletion 17p because they were not included in our study with the RESONATE-2 study because we did not think it was appropriate to give patients with deletion in 17p chemotherapy. So those patients were excluded from the RESONATE-2 study. So we focused our attention on the patients that had deletions 11q versus other cytogenetic changes, and it seemed to bear itself out, that the patients with 11q were doing not only as well, but seemed to be doing better than patients who did not have 11q minus or deletions in chromosome 11. So clearly there's something going on here, and it would indicate maybe it's not so incorrect to tell a patient that they don't have bad disease, just maybe bad therapy. And as we change our therapies, we may change how we view these so-called prognostic markers. As I mentioned earlier, there's a difference between a prognostic marker and a predictive marker. A predictive marker is a marker that helps to predict how well you're going to do with this given therapy. A prognostic marker is one that is telling you how well you're going to do overall. That should be independent of therapy. And so I think what we're seeing is a divergence between predictive markers and prognostic markers. That's improving the prognosis, but it's also, we have to say that the predictive markers that we had before with, say, chemotherapy are perhaps no longer applying to newer types of therapy. That's quite exciting, because we shouldn't say that it's a done deal, that if you have a bad marker, or so to speak, again, it just goes back to saying we just need improved treatment options, and improved drugs, and improved combinations of therapies. Well, I think that patients should have cytogenetic testing. The FISH testing is very useful, and it's available everywhere, and it should be applied. It's an easy test. It can be run on leukemic cells in the blood if they are present, or we like to look at the leukemic cells in the marrow because we find a higher proportion of them there. And this gives you invaluable information. We also do another test, which is to look at the chromosomes. And for that, we stimulate the cells and we try to induce some proliferation. And what we can do then is we can now take the cells and look at the chromosomes themselves. And that could spot genetic changes which are unusual or rare than the ones that are detected by FISH. Several years ago, we got the cytogeneticists together at a lot of the institutions across the country under the auspices of the CLL Research Consortium. And we got them all together in the Mayo Clinic, and we came down with a unified way of stimulating the cells to do what we call a karyotypic analysis. And the cells are stimulated with a cocktail which includes what's called an oligonucleotide, which stimulates the cells to grow. And then they look at these cells, and what we find is that you can detect sometimes translocations, which are one chromosome latching onto another chromosome, or deletions, and you could not detect those by standard FISH analysis. And that's what we have been able to define as complex karyotype, and we find 3 or more different genetic changes within the cells that we're analyzing. And that's seemingly very important as well, and I would encourage that we get that. Obviously, I tell patients that the simpler your genetics are, the better off you are. If you have genetics that seem like the chromosomes have mixed themselves up like they were put into a warning blender, that could be difficult. And it could indicate that the leukemia has an ability to maybe resist some forms of treatment. And we're trying to look at the significance of that right now. I think that getting these tests is very important. Looking at other genes such as p53 we think is important too, because as I mentioned before, if p53 is not present, the ability to respond to chemotherapy is very much reduced. So knowing ahead of time, it's like you're mapping out a journey. If you don't check the weather report and you're going down the highway and you find the highway's closed because of a snowstorm, that would indicate you haven't done your job of checking the path before you go there so as to avoid trouble down the road.